We are proceeding to the fourth session of today. May I request Dr. Shashikala Kannan of the Institute of Neurological Sciences, VHS Chennai, to come on to the dais, and Dr. Muhammad Ghani, SRM Medical College, Chennai, to come on to the dais. Leah. And Dr. Stanley C. McAdam, CSI Hospital, Bangalore, to chair the session on the topic Chronic Disease Management in the Elderly, Problems and Solutions. Over to the chairman.
Good afternoon, everybody. We come to this interesting session, two interesting topics for the day, is stroke and dementia. Stroke is the second leading cause of death, of which two-thirds of which occurs in our developing countries. And it is the single largest cause for hospital bed occupancy amongst the elderly in the neurological wards. So it's of great economic importance and it should be treated as a multidisciplinary subject. And we have an authority on stroke here, Professor V. Natrajan, a small write-up about him. Professor V. Natrajan is DM Neurology, is retired Professor of Neurology, Head Institute of Neurology, Madras Medical College, Chennai. He served the MMC from 1982 to 2010. He is a Commonwealth Medical Fellow in the US for 1 year on stroke and epilepsy, and visiting fellow at the Massachusetts General Hospital, Boston, USA. His areas of special interest are in stroke, epilepsy and headache. May I invite Professor V. Natrajan to give his talk on stroke in the elderly, problems and solutions.
Thank you, Chairpersons. I am grateful to Dr. ESK for giving me this onerous task of covering stroke management in 30 minutes. I'll be hitting only the highlights. I know we have a mixed audience. So I shall be, being a physician, I shall talk on the medical aspects of stroke care. And I will be mentioning briefly about the rehab aspects also, but we shall take it up if there are specific questions or specific areas of interest. We shall take that during the discussion time. And as you know, strokes, the main chunk of strokes happen to be ischemic strokes or infarcts, which are about roughly, it's a ratio of 4:1, with 80% being infarcts and 20% hemorrhages. The approach here would be, as a patient presents in the emergency room, and how we would approach the patient when he presents in the ER, and what would be the management thereafter. That is how I will proceed on this talk. So first of all, if a person presents, we need to identify that the person's problem is a stroke. And how do we identify that? By and large, a person presenting with a stroke has a focal deficit. It is of abrupt onset, and the courses over the next, say, a few days, it either improves or is static, and at times may worsen. This worsening may be smooth or it may be fluctuating as well, or stuttering. But this is a retrospective aspect. So any person presenting with a focal deficit of abrupt onset, stroke would be an important differential diagnosis. From there on, we shall see how we approach the problem. Now, assuming it is a stroke, it's not easy to differentiate infarcts and hemorrhages. One of the crucial things which we need to do when the patient presents to us with a stroke, or what we think is a stroke, is to find out whether it's an infarct or a hemorrhage, because this is a major division here as far as management is concerned. And for this talk, I will be talking mostly of ischemic strokes, because apart from the management with thrombolytics and antiplatelet agents, the management for both would not differ much. Specific issues like management of certain surgical aspects of hemorrhages, as well as surgical aspects of ischemic infarcts where we do decompression, will be out of the scope for the present, but can be taken up for discussion if required. Continuing on the same vein, now how do we establish the diagnosis of a stroke in the emergency room? There is no specific or sensitive test which says 100% we can say this is a stroke. We'll have to, as has been stressed right through, we'll have to depend a lot on the history. History is the fulcrum for making a diagnosis in any neurological disorder, and it is the same with stroke as well. So characteristic features in history, which I had already mentioned about the abrupt onset, focal deficit, and on examination confirming the focal deficit, and these we need to differentiate from stroke mimics. We shall see what are the stroke mimics shortly, and based on these clinical features we'll have to differentiate them from stroke mimics. Of course, an early CT would be necessary. See, the problem with CT is within the first few hours, the CT could be normal, and thus brings us again to differentiate from stroke mimics clinically. So, what are the stroke mimics? Seizures. A person could present with a seizure, and following a seizure, a person could have a focal deficit as well, which is called as the postictal deficit following a seizure. In that case, it might very well mimic a stroke, and within the first few hours, it might be difficult to see whether this weakness resolves, suggesting that it is a seizure-related postictal deficit or and differentiated from a stroke. Similarly, migraine. We have migraines wherein complicated migraine or complex migraine are associated with neurologic deficit in the form of weakness, in the form of ophthalmoparesis, and sometimes confusion as well, which can very well simulate a stroke because that is also abrupt in onset and with focal neurologic features. Syncope already touched upon in the previous lecture, so also was acute vestibular dysfunction, which can sometimes, not always, it's not very difficult to differentiate this from strokes, but it could pose problems at times. Hypoglycemia again is a known mimic because hypoglycemia can be accompanied with focal deficits. So we would again have to check the blood sugar to make sure this is not hypoglycemia and differentiate it from stroke. Metabolic encephalopathies has been touched upon by the previous lecture on delirium. Again, by and large, not a great problem in differentiating this from stroke, except for some strokes which present with confusional episodes or delirium, wherein there is no focal deficit, particularly if it happens to be an involvement of the right temporal lobe, where there may not be much of associated findings, and in that sense, it might be a problem to differentiate from a metabolic encephalopathy. Of course, the blood results, blood biochemistry, once we have that, should help us differentiate. Drugs, space-occupying lesions, particularly tumors or bleed within the tumor, can mimic a stroke because by its acute presence, acute onset deficits, particularly tumor with an edema, and in our setting, a granuloma with an edema can mimic a stroke as well. Infections like herpes simplex encephalitis, we should be wary about. Sometimes it can present acutely with neurologic deficits suggestive of or raising the doubt whether it is a stroke. Subdural hematoma again is a form of stroke in the sense, broad sense, because there is a hemorrhage, but this is outside the parenchyma, and this can also produce weakness. So, but it would be rather a slow onset weakness rather than an acute onset weakness. One might wonder why neuropathy is brought into this picture. As all of us know, the Saturday night palsy can produce a radial nerve involvement and produce a wrist drop. Many a time we have been fooled by a wrist drop thinking that it might be a stroke because focal infarcts in the parietal region or subcortical region can produce only an involvement of the hand, and it can mimic a wrist drop unless we carefully examine and pick up the sensory finding also. And similarly, at times, this is rare, an isolated and facial paresis can produce problems differentiating it from a low motor neuron paresis. These are, it does happen. We need to be aware of that. Next, talking about the types of stroke. What are the types of stroke? Of course, ischemic strokes can be ischemic infarct. TIA is always a retrospective diagnosis because we can establish the diagnosis only after the patient has improved or the deficit has recovered. Intracerebral hemorrhage, subarachnoid hemorrhage. These are the types just to complete on strokes. Now, question is, what do? We see the patient, we think it is a stroke. how do we proceed, what do we do in the ER? The first thing which we need to do is to stabilize the patient, and then once the patient is stabilized, assess the patient. We'll see how we go about this. And once this assessment is done, the need is plan for definitive therapy. As I said, we will be focusing on ischemic strokes, and here plan for definitive therapy is, in ischemic strokes, there is only one definitive therapy, and that is thrombolysis. So that is where we should be focusing our attention, because the earlier we do, the better is the success. So the mantra is, be quick, as soon as possible, establish the diagnosis and plan the treatment. All these processes will have to be done simultaneously. And what are these processes? As with anything, any person presenting in the ER, the first thing we look at is the airway patent? Is his breathing okay? Is his circulation adequate? This is the first thing we need to do. We need to establish the airway, see that the breathing is okay. Absolutely no harm in giving oxygen by prongs for these patients, because it would help. And then look at the circulation, and it would be preferable, when we are not sure at that point, as soon as the patient comes in, to keep the head end flat so that the brain is well perfused, or we increase the cerebral perfusion and then assess him further. Now the question starts, we need to find out what was the onset time. Why is this important? Because, as I said, the only definitive therapy is thrombolysis, and for thrombolysis, time is absolutely important. That is why the adage goes, time is brain. We need to thrombolyze the patient as early as possible. The outside limit is at present 4.5 hours, but the earlier we do, the better is the result. And so we need to do as early as possible. The other point in assessing the patient is to find out how severe is the deficit. How do we assess this deficit, how severe it is? We have a quantifying scale, and there is no better scale than the National Institute of Health stroke scale, which would tell us the severity of the stroke which the patient has had. This is important because it is by itself an independent important predictor of the outcome as well as the prognosis. So having done this, we immediately from the ER just move the patient to the CT scan. It is always advisable to have an in-house CT scan, and straight away inform the CT scan people that the patient with a stroke, presumed stroke, has come and we need an urgent scan, and he or she takes priority over other radiological procedures which are waiting. This patient takes the priority. It will be difficult to do an emergency MRI, though MRI would be preferable to make assess and decide about the thrombolysis, but most often MRI is not available and we'll have to do with the CT scan. Okay, we find that there is no blood on the CT scan. We have excluded a hemorrhage, so the patient has to be treated as an ischemic infarct. Now the question is, if he comes within 4.5 hours, that's the golden period, as I already mentioned, we'll have to process him for thrombolysis. And what do we aim by doing this thrombolysis? We try to get the artery open and establish the blood flow again, so that we preserve as much of salvageable tissue as possible. Along with this plan, we also order other investigations, blood tests, which includes glucose, urea, creatinine, prothrombin time, partial thromboplastin time, coagulation factors. All this we order, but we do not necessarily wait for these by the time we plan the thrombolysis, if the patient comes within that required time window of 4.5 hours. Now, just a concept about ischemic stroke. We have a core ischemia happening in any ischemic stroke, and this is called the infarct zone. Generally, by and large, if that area receives less than 12 ml per 100 grams of brain tissue per hour, that is very likely to undergo necrosis and cell death. Necrosis, apoptosis, cell death is bound to happen there. And that area we will not be able to salvage whatever procedure we do. It is the penumbral zone. Now, what is the penumbral zone? It is the zone surrounding the ischemia. There are three zones: infarct zone, penumbral zone, and oligemic zone. Oligemic zone is still better. The penumbral zone is the area surrounding that area of infarct, which is potentially might turn into an infarct, and that is the area we need to salvage to prevent further deterioration or loss of function. The sole aim of treating the patient acutely with thrombolysis is to preserve this penumbral area. Here, generally, the blood flow will be around 12 to 25 ml per 100 gram tissue per hour. So the whole concept of acute treatment is to preserve this penumbral zone. And how do we do it? We do it with tissue plasminogen activator. And this tissue plasminogen activator can be given intravenously, which is the most simple form and can be done in any way, just like as we do the thrombolysis with streptokinase for myocardial infarction. But this is a little more complicated because we need to have a CT scan done, CT has to be interpreted, and then taken up for thrombolysis. Intra-arterial thrombolysis also can be done. The advantage with intra-arterial, we get an extended time window from 4.5 can go to 6, at times to even 9 hours. Other procedures which can be done are endovascular recanalization, wherein what do we do is we go by catheter into the vessel itself and take out the thrombus. So these are procedures which are being done currently as a measure of opening up the blood vessel and restoring the blood flow. We also need to ensure adequate cerebral perfusion. This is concurrent with thrombolysis or no thrombolysis, and that we do by ensuring euvolemia. Any patient, it is preferable who comes with a stroke to give a 250 to 500 ml of normal saline. Always the IV fluid should be an isotonic solution, and we give 250 to 500 ml in half an hour first, and then take it as per requirement to maintain normal volume. BP needs to be supported. We'll talk about the BP. I'll come to that because that's an important component. And as I mentioned earlier, initially it is better to have the head end flat so that we ensure adequate perfusion. Of course, subsequently, during the course of the stroke, when they develop cerebral edema, then we might have to bring the head end up by 30 degrees. Now, when do we treat high blood pressure? This is always a question which crops up in the management of stroke. High blood pressure needs management when the patient is going to be taken up for thrombolysis. Any pressure about 185 systolic will have to be treated when the patient is going to be taken up for thrombolysis. But otherwise, it is only when the systolic is more than 220, or when the patient is having an associated congestive cardiac failure, myocardial infarction, dissecting aneurysm of the aorta, or hypertensive encephalopathy. In these situations, we necessarily have to bring the BP down. Otherwise, the guideline is we treat blood pressure only when the systolic is about 220 or the diastolic is over 120. And by and large, in these situations, we aim for only a reduction of 10 to 15% or a mean arterial pressure around 130 millimeters of mercury. This is the way we treat the blood pressure in a person with a stroke. Now, what about acute antiplatelet and anticoagulant therapy? Now, what we mean by acute is immediately after the stroke or at the time of stroke. This is apart from thrombolytic therapy. If a person does not qualify for thrombolytic therapy, or after thrombolytic therapy, 24 hours later, we start on antiplatelet. If the person does not qualify for antithrombolytic therapy, then the patient is given acute antiplatelet therapy. Now, the only drug which has been tested for which we have evidence is aspirin. The aspirin is effective, but the effect is just marginal. And what does one do when the patient is already on aspirin? It's not at all uncommon for patients to be on antiplatelet therapy already, either because of a previous stroke or for his cardiac condition, and then present with a stroke. In that situation, obviously, that aspirin has not been adequate. So, again, there is no guideline or evidence-based study, but we borrow a leaf from our cardiologists. Cardiologists always do dual antiplatelet therapy. So, borrowing a leaf from them, these patients can also be put on clopidogrel in addition to aspirin, can even be preloaded with clopidogrel just as they do for stent procedures. So, we can give 300 or 375 milligrams of clopidogrel followed by aspirin or antaspirin. Anticoagulant, it's widely used in our setup Almost every patient who does not qualify for thrombolysis is put on anticoagulant, but there is no evidence so far to say that anticoagulant is effective. And even in this setting, what happens if the person has an embolic stroke, a cardioembolic stroke? Even there, an atrial fibrillation. In the acute phase, we are talking of the acute phase, the recurrence rate of a stroke when there is atrial fibrillation is only 5 to 8% in the first 2 weeks. And this is not reduced by early anticoagulation. So in other words, there is no need to start immediately on anticoagulation any person who has had a stroke. It is useful, of course, for secondary prevention of stroke in patients with atrial fibrillation or a cardiac embolic source. So having seen the management during the acute phase, I move on to the secondary prevention, what we need to do when we talk of secondary prevention. Now, secondary prevention is person has already had a stroke, patient has presented with a stroke. Now we need to see what we can do to prevent another stroke from happening. So here we need to know what is the mechanism which has caused the stroke so that we can adequately take measures to prevent a secondary stroke. As all of us know, broadly, strokes occur because of atherosclerosis of the large vessels, namely the internal carotid or the middle cerebral. And other sources would be a cardioembolic source from either the heart or the arch of the aorta. And atrial fibrillation is a known potential cause of stroke, apart from regional wall akinesia and paradoxical embolism when a person has a patent foramen ovale. Now, persons with hypertension as well as diabetes are prone to have involvement of the small vessels. By small vessels, we mean the arterioles, the small vessels which are deep inside in the brain, in the basal ganglia, and broadly the thalamus, the striatum. That is the deep portions of the brain which are supplied by these small vessels. They are prone for strokes, both ischemic strokes as well as hemorrhagic strokes. Then there are unusual causes of stroke which we also must be aware, particularly a type of encephalopathy called Binswanger's encephalopathy, where there is predominant subcortical involvement, multiple strokes happening involving the small vessels. We have amyloid angiopathy, particularly in the elderly about whom we are talking about. They have both hemorrhages as well as ischemia, apart from a leukoencephalopathy-like picture. That is an encephalopathy predominantly involving the white matter due to ischemia, and this is a special set of population wherein we do not have any effective treatment for these patients who have this amyloid angiopathy, wherein the blood vessels are affected by amyloid deposition. Then other unusual causes, what is called as a genetic cause or CADASIL, where we have a subcortical arteriosclerotic lesions even in the young age. So, and of course, mitochondrial disorders. These are unusual causes, each of which will merit treatment depending on what is the cause. Cryptogenic, of course, where we do not find out why the person has had a stroke. It's not unusual. Quite often we are not able to find out, at least in about roughly 1/5 of the persons with a stroke, we are not able to find out the exact cause as to why they had a stroke. So when we talk of secondary prevention, necessarily we'll have to give attention to the risk factors. What were the risk factors in that particular person, and how are we going to protect him from those risk factors? Obviously, we will be talking only about modifiable risk factors because non-modifiable risk factor is out of our influence. So this risk factor screening would include cardiac evaluation by an echocardiogram, at least an echocardiogram, which most often suffices. Blood pressure monitoring both in the supine as well as the standing position, the fasting lipids, profile of glucose, and necessarily homocysteine if the person happens to be a young person, particularly above below 40 years of age. It's not unusual. We do have quite a significant proportion of our patients having folic acid deficiency and high homocysteine. Smoking, of course, all of you are aware, is a significant risk factor as far as strokes are concerned. Now moving on to other aspects apart from the medical aspects, a word about secondary prevention. Secondary prevention again is we do, apart from controlling the risk factors, we put the patients on antiplatelet agents. Of course, the most widely used and for two reasons. One, because that's the one which has had the large number of studies done, and that is where what is universally prescribed and it is economical is aspirin. But if for some reason the person is not sensitive to aspirin, or if aspirin cannot be used as it does not suit him, then we move on to clopidogrel. There is yet another agent which has been found to be equally effective, and that is cilostazol. Cilostazol and clopidogrel might be more expensive compared to aspirin. Of course, from the ECAS-3, this is the European stroke trial, which has shown that dipyridamole and aspirin in a fixed combination of extended release dipyridamole 200 milligrams with 50 milligrams of aspirin is probably I would say the best. In terms of current, there is no head-to-head comparison, but probably BD dose or twice-a-day dose of cilostazol and dipyridamole extended release with aspirin would be comparable, and the next would be clopidogrel and aspirin. This is about secondary prevention with antiplatelet agents apart from controlling the risk factors. Now we move on to what do we do with regards to stroke rehab. It's again similar to myocardial infarct. What do we say? We mobilize the patient as early as possible. The same applies to stroke also. Only thing, we'll have to start as early as possible, provided the patient is stable. We shall see there are some caveats. We'll see what are those. And it has to be a multidisciplinary rehab team. Whenever we have such a team, the results are better. And why do we do this? Why do we start early? Is to prevent complications, the minimize impairment, as well as maximize the function. Certain complications or deteriorations are known to happen in stroke patients. We should be aware of it. Probably as we go through the rehab, I'll be mentioning about those as well. Swallowing is one. Swallowing, mostly, at least about 70% of stroke patients have swallowing difficulty initially. Even though if it's a unilateral stroke, supratentorial, they have swallowing difficulty. So the first assessment needs to be, we'll have to give them a water drinking test, or we give them, it's advisable to give 90 ml, if not at least 30 ml of water, and see whether they are able to swallow it without cough happening immediately after swallowing. Once the patient is able to do that, only then he is fit to take oral feeds. If not, it would be preferable to have the patient on NG tube at least for the first 2 days or 3 days, by which time they recover the swallowing function. Then language function. This is the role of the speech therapist I am talking about now. So the speech therapist is involved with assessing the swallowing as well as the language function. As I mentioned, dysphagia is quite common, and once a person has a dysphagia and is not able to take orally, then we have certain problems arising just because of that, namely malnutrition, dehydration, and aspiration is one which we'll have to be, which probably is, we should dread about, because that is the major problem during the acute phase of stroke, causing all sorts of complications as well as mortality if it goes undetected. So to overcome this swallowing, we can make use of the nasogastric tube and of course percutaneous endoscopic gastrostomy. This can be done as early as the first 5 days if the patient is not able to swallow, to ensure better nutrition. But in our setup, we do not do this as much as it is being done in the West, and probably we have managed to get away without doing PEG. Very seldom do we need PEG. We are able to manage with nasogastric tube feeding itself. What about physical therapy? Starts from day one, or as I mentioned earlier, as soon as the patient is stable, we start. Only thing is, we need to make certain that the person has or does not have postural hypotension, and he maintains BP both in the supine as well as the standing position. Once we have ensured that, then we go all ahead to move the patients out of the bed, transfers, and already in the morning it was mentioned about balance training, gait training, and as far as possible, make him do all normal movements. To regain normal movements, we would have to give training towards that. And the role of the physiotherapist as well as the nurse is absolutely important in this setting, to mobilize them. The role of the occupational therapist, of course, they do, it's important that the occupational therapist comes in as early as possible once the patient is able to move the limb, to ensure better motor coordination and reinforce the strength, as well as assess the tone and sensation and plan for the activities of daily living. They can make use of the braces, splints as required, and of course make use of the compensatory phenomena from the non-involved limb as well as facilitate the involved limb as well. This is the brain plasticity. By compensation and facilitation, we improve the brain plasticity, though by contralateral movement, even on the side of the stroke, the patient's, the areas adjacent to the area of infarct starts functioning or takes over the function. Last but not the least is the psychosocial evaluation, which is absolutely important because we need to educate the family as to what the person has gone through, what stroke meant for him, and what is likely to, what are the problems the patient as well as the carer are likely to face. And this should be told both if the patient can understand at that point of time to the patient as well as the family. It is also important to suggest the lifestyle changes which are required, taking into consideration the individual risk factors which these patients have, and also educate them about the medications. One of the problems is with both cardiac patients as well as the patients with strokes, they need long-term medications and they need multiple medications. We already discussed about polypharmacy, and this is one situation where polypharmacy has to be given to patients for control of diabetes. If the patient most often have multiple risk factors, and each of the risk factor has to be taken care of by medications, and necessarily they'll have to be on multiple medications. So it becomes important for us to educate both the patient as well as the carer which of these medications are absolutely important. What happens is 8 or 10 medications are invariably given, and patients, because they have so many medicines to take, and probably because of the financial difficulty as well, they tend to not to take all of the medications, and what could happen and what does happen is they might miss out on the important medications which they necessarily have to take because there are so many medications. This also has to be educated to the people. The other 4 things, depression is quite common after stroke, and so incontinence is a major stress factor for both the patient as well as the family. They have to be told about that, how to overcome incontinence. Fortunately, it's not a persisting problem as far as strokes are concerned unless the patient has had multiple strokes, when of course the incontinence is likely to persist for longer periods. We should take care that these patients as far as possible are not catheterized, and we should advise either a urocondom or a condom drainage, or a drainage with a urine pot, rather than putting them on catheter unless and otherwise the bladder is distended, or they are not able to empty the bladder, or we need an accurate measurement of the output. Apart from these situations, we should as far as possible avoid catheterization. Delirium and decreased arousal level has already been extensively talked, and Mac just mentioned that about 20% of stroke patients are likely to be in a delirium. So that we should keep in mind and handle appropriately, as he had mentioned. So friends and colleagues, you would see that this is a teamwork. Stroke management is essentially a teamwork comprising of, apart from the physician, which need not necessarily be a neurologist, any person interested in stroke, then physiotherapist, the nurse, the occupational therapist, the radiologist, and the social worker as far as occupational therapist, and the counselor. All these people are involved, and a cohesive team is all that is absolutely needed. As you can see, wherever there has been a stroke team or a stroke unit, the results are always better. So this is what is most important. And with that, thank you for this opportunity. Thank you very much.